Okay, so we got your request for a deep dive. You wanted a strategic look at remote clinical coding in the UK healthcare system.
Yeah, focusing on how it actually works operationally and the financial side too. It's quite complex.
Definitely. Our mission here is really to unpack the role of clinical coders. They're quite specialized, aren't they?
Absolutely. They're right at that, critical point where clinical care information meets the NHS's financial structure. Indispensable, really.
So their main job is translating, taking all that complex medical language diagnoses, treatments, procedures from patient notes.
And turning it into standardized alphanumeric codes.
Yeah.
And this isn't just admin, it's fundamental for planning, for public health tracking, and critically for how NHS trusts get paid. That whole payment by results system, PBR.
Ah, PBR, right. So accuracy is paramount there.
Totally. Which is why they need mastery of the official systems. That's ICD-10 for diagnoses, that's the WHO standard, and OPCS-4, which is UK specific for procedures.
And you mentioned Cinema CT playing a role.
Yes, SNOME-ACT is sort of the underlying language ensuring different systems can talk to each other. It's also really important groundwork for bringing in more automation down the line.
Okay, which brings us to a big challenge.
Yeah.
Security. You want the flexibility of remote work, but you're dealing with incredibly sensitive patient data. That feels like a paradox.
It is. You absolutely need intense operational control. You just can't have patient records ending up on someone's personal laptop.
So how do they lock it down? What's the tech involved?
Well, it all hinges on compliant infrastructure. Think DSPT standards, data security, and protection toolkit. For most, this means, first, mandatory NHS smart cards.
For authentication, right? Proving you are who you say you are.
Exactly, and it enforces role-based access control, or RBAC, so you only see the specific data you need for your coding task, nothing more.
Okay, smart cards for access. What else?
The second big piece is usually virtual desktop infrastructure, VDI.
VDI. How does that work for a coder at home?
VDI is key because it means the coder isn't actually working on their own computer's operating system. They connect securely to a virtual machine hosted centrally, likely within the NHS's secure cloud environment.
Ah, so the data, the coding software, it never actually leaves the NHS network. It just streams to their screen.
Precisely. The sensitive information never resides on their local device. That's absolutely core to meeting those DSPT requirements for remote working.
Right, that makes sense technologically. But how do you verify the person doing the coding is, qualified and understands the security protocols, especially working remotely?
That's where accreditation comes in. The absolute gold standard is the National Clinical Coding Qualification, the NCCQ.
And getting that makes you an accredited clinical coder, an ACC.
Correct. And having that ECC status is pretty much the minimum ticket required for remote coding work. It proved proficiency in the coding standards and the data security aspects.
It's clearly a skilled role. And the market reflects that, doesn't it? We saw figures suggesting strong growth, like over 10% CAGR.
Yeah, it's booming. But how coders are paid varies wildly. If you're permanent NHS staff, you're typically on agenda for change bands, maybe band 5 or 6.
Which is, what, roughly 30K to 38K, maybe a bit more with experience?
Around that, yeah. But the picture changes dramatically for experienced ACCs working as locums or contractors. Daily rates can easily hit £500, sometimes more.
£500 plus a day.
Oh.
Wow. But then there's the IR35 issue, the off-payroll working rules.
Yes. IR35 has a massive impact, particularly in the public sector like the NHS, if the NHS assesses a contract as being inside IR35.
Which means they see the contractor as essentially an employee for tax purposes.
Exactly. Then the NHS has to deduct income tax and national insurance contributions at source, just like for a regular employee. This significantly reduces the contractor's take-home pay.
The effect of that is?
Well, it often makes direct contracting with the NHS less financially attractive for highly skilled, experienced coders. It pushes them towards working via third-party outsourcing companies who might structure things differently.
So, ironically, the rules designed to ensure tax fairness might actually be pushing talent out of direct NHS engagement and towards potentially more expensive outsourced solutions.
That's certainly an argument you hear. It creates a real tension in the market. It's a structural factor that kind of reinforces the outsourcing model.
Okay, while all that financial and structural stuff is happening, technology isn't standing still. AI, computer-assisted coding, that's coming, isn't it?
It's already starting. AI and HEEC tools are getting better at handling the more routine, high-volume coding tasks, the straightforward stuff.
So does that mean the human coder is becoming obsolete?
Not obsolete, but the role is definitely evolving. It's shifting away from purely manual data entry
Towards what, then?
towards higher level functions. Think quality assurance analyst, digital auditor, validating the output of the AI, ensuring compliance, interpreting complex cases the AI struggles with, managing the overall data quality.
So using that secure remote setup we talked about, the VDI, the smart card, the ACC of the future, will be overseeing the automated systems.
That's the direction of travel. They'll be validating AI-generated codes, making sure the trust gets the right reimbursement under PBR, and maintaining those crucial regulatory standards. It becomes less about input, more about validation and expertise.
Okay, let's try and summarize. Remote clinical coding. It's definitely viable, secure, and scalable.
If the trust invests in and strictly mandates that high-security setup, VDI, smart cards, strong access controls, risk management is key.
And the profession itself is moving from data entry towards essentially high-value auditing and quality assurance.
Precisely. A significant shift in required skills.
Which leads us to a final thought for you, our listener, to perhaps chew on. Given that IR35 complexity seems to structurally push some of the most skilled, experienced coders towards outsourcing partners, how can the NHS itself strategically adapt to better retain and develop its own in-house permanent coding workforce? How does it keep that critical financial and data quality expertise internal for the long run?